Hi again. This is a CT scan of the chest on a 21-year-old female patient who presented with chest pain. One striking abnormality here is the presence of these lines. These are septal lines. The septal lines are connective tissue structures that form the backbone of the lung. So what you see here is a smallest building block of the lung. Septal lines are also seen on chest radiographs as what we know famously by the name of curly bee lines. Whether you're seeing curly bee lines on a chest x-ray or these septal lines on a CT scan, they're not this obvious unless they're thick. A more specific name for this is interlobular septal thickening, and this could be divided into smooth, nodular, or irregular. We talked about this in a prior clip, and we discussed the secondary pulmonary lobule and the differential diagnosis for septal thickening. We'll just concentrate here on the smooth septal thickening that you see. The major differential for such an appearance would be pulmonary edema, whether cardiogenic or non-cardiogenic in nature, and lymphangitic carcinomatosis. The list of differential for such an appearance is actually longer than that, but this is to simplify what we're talking about today. Another observation on this patient is the moderate thickening of the wall of the small airways. So this bronchial wall thickening is a nonspecific finding that may occur with many diseases. Since we're thinking that this patient has smooth septal thickening that might be related to pulmonary edema, there's a good chance that this is related to edema as well. Meaning that what you're looking at here are thickened, congested airways. By the way, for juniors, a normal small airway like this should be seen with difficulty, and if you see a wall, it's classically pencil thin. Looking more carefully, you'll notice that there is heterogeneous appearance of the lungs with areas that are ground glass versus areas that are dark, in addition to a patch or two of consolidation. All these features can be seen with pulmonary edema, so the picture is well explained till now. Now to the more interesting part of the case. What's causing this pulmonary edema in this previously healthy female patient? Let's look together at the soft tissue part of the examination. Now you notice that you have this large, low-density filling defect within the left atrium, which is dilated. And although the left ventricle is subjectively of normal size, the right ventricle and right atrium are dilated as well. Finally, in a normal patient, the pulmonary artery should be smaller than the adjacent ascending aorta. Here, the case is the opposite. So you have dilatation of the pulmonary artery, dilatation of the right ventricle, dilatation of the right atrium, and of the left atrium. So what could be the cause of this filling defect that's centered within the cavity of the left atrium? Let's review our basic principles. The most common cause of a filling defect within the heart is a thrombus. What about neoplasms? The most common neoplasm involving the heart is metastasis. Remember, clots are way more common than metastasis. Metastasis is way more common than primary cardiac tumors. The most common primary cardiac tumor is a myxoma, and we'll talk more about that later. The most common benign cardiac tumor is a myxoma again. The most common malignant primary cardiac tumor is sarcoma, typically angiosarcoma, but could be other types. Note, if I change the wording a bit, if I say the most common malignant cardiac tumor, it's metastasis, but if it's the primary malignant tumor, it's sarcoma. Although thrombus is the most common, in a young patient who has no risk factors, she was healthy before, a primary cardiac tumor should be considered. Given that primary cardiac tumors are more common in the form of myxoma, you'd favor that over a sarcoma. Add to that, myxoma is usually confined within the chamber. That's in comparison to malignant primary cardiac tumors, which are infiltrative, involve more than one cardiac chamber, are associated with hemopericardium, or may be associated with lymphadenopathy and metastasis. Now to another famous fact, the most common location for a cardiac myxoma is the left atrium. Although it happens, it's very rare to see myxomas in the right atrium or in the ventricles. So let's talk a little bit about atrial myxoma. As we said, it's the most common primary cardiac tumor. It's the most common benign cardiac tumor. It's classically seen in the left atrium. Another classic feature is that it's typically associated with an attachment to the interatrial septum. And this attachment could be broad-based, giving a sessile lesion, or like a stalk, giving a pedunculated lesion. Another feature is that if the lesion is mobile, especially if pedunculated, it could move into or out of the mitral valve. So it could protrude through the mitral valve, and in this case, you'd suspect that this is what's happening. This is the left ventricle, this is the left atrium, and this is the line in between. And in that case, this could occlude the opening of the mitral valve and act as if it is a case of mitral stenosis. And now you understand, as a medical student, we used to talk about the differential diagnosis of pulmonary arterial hypertension, and we used to include myxoma in that. And if it's acting as a stenotic lesion, this would explain why you have dilatation of the left atrium, the right-sided cardiac chambers, and the pulmonary artery as well. If the myxoma is large enough to impede the venous flow or to occlude the mitral valve, it could give you congestion. And that explains the septal thickening, the thickening of the small airways, and the heterogeneous appearance of the lungs. Here's an image from an MRI on this patient. This MRI sequence is with contrast. It's real time, and it's called first pass perfusion, where you could follow the contrast bolus. It's a very neat sequence, since you could see the contrast filling the right-sided cardiac chambers, then going to the lung, and then back into the left side. And of course, the filling defect in the left atrium is seen nicely here. Not only that, you could see the prolapse of the lesion into the left ventricle. Here's a different sequence in motion, which we called a white blood Cine sequence, or scientifically speaking, SSFP. I will try to talk about these sequences hopefully in future clips, but let's just see what's happening here. There is this lesion in the left atrium. It has this cauliflower appearance or front-like projections. It's attached to the septum. And nicely seen here, you could see the systolic phase of the left ventricle versus that of the diastolic phase. Systolic ventricular contraction, the mass is pushed towards the left atrium. However, the opposite happens when you have ventricular diastole and relaxation. The mass prolapses through the mitral valve into the left ventricle. And this large lesion has an attachment to the interatrial septum that is actually smaller than what we thought. So this attachment is a stalk-like attachment that allows this lesion to prolapse into the left ventricle and comes back again to the left atrium. Overall, the features are so classic for a benign primary cardiac tumor known as a left atrial myxoma, and this was the case here. To summarize what we talked about, when you see smooth interlobular septal thickening, think about pulmonary edema and lymphangitic carcinomatosis. Even when you're looking at a chest CT, make sure that you look at the cardiac structures carefully. The most common intracardiac filling defect is a thrombus. The most common cardiac neoplasm is metastasis. The most common primary cardiac tumor is myxoma. The most common benign primary cardiac tumor is myxoma. The most common malignant primary cardiac tumor is sarcoma. The most common location of a myxoma is in the left atrium. That's why it could act as mitral stenosis. It has a classic broad-based or narrow attachment to the interatrial septum, and it may prolapse through the mitral valve during the cardiac cycle. Now it makes more sense to remember what we used to talk about when we were students, is that myxoma is a differential diagnosis for pulmonary hypertension. Whether static or dynamic images are acquired by MRI, MRI is a great way to assess cardiac tumors. And I'll leave you with this image. Thanks for watching, and see you with more cases later this week. This is a really good case for seniors. I think juniors would enjoy it as well. This is a 20-year-old male patient who presented with seizures. Here's another look. Seniors may have noticed the abnormality, but I'll go a little bit over some normal structures before we proceed so juniors could follow. So this is a normal adult brain. This is a different normal patient. As we discussed before, the gray matter on a CT scan of the brain looks a little bit whitish, while the deeper white matter looks darkish. So it's the opposite of what you think. You have deep structures here which are gray matter as well, like the basal ganglia and the thalamus. This dark area here is CSF contained within the ventricular system, and these are the lateral ventricles. The right and left lateral ventricles are separated by this line here, which is called the septum pellucidum. And as you go lower down, you will notice that there is a slit-like CSF space. This is the third ventricle, which connects to the lateral ventricle. Notice this area here, which converges from the lateral ventricle into the third ventricle. This is the communication, which is called the foramen of Monro. So the interventricular foramen of Monro opens the lateral ventricle to the third ventricle here. Another thing that I'll need to show you here is the sagittal anatomy for a few anatomical landmarks so we understand the other abnormal case. If you go to the side, you'll notice that you have one of the lateral ventricles. To the other side, this is the other lateral ventricle. And back to the midline, you'll see that this is the slit-like third ventricle. And here you have the floor of the third ventricle, this line here. We'll talk in details about the floor of the third ventricle, but if you want to know more about its specific anatomy, you could go to the Radiology Bits YouTube channel. And on the channel, check the first Radiology Bits Tips and Tricks episode. So now you know what's needed to understand regarding the abnormal case. Let's go there and take it step by step. This is back to the abnormal case. On the normal case, you notice that the ventricular lining should be smooth, something like this. The ventricle should be as smooth as what you see here without thickening or enhancement. Anatomically speaking, this lining here is called ependymal lining. So if we have an abnormality in these areas, we'll call that ependymal or subependymal abnormalities. Now let's look more carefully. Although the lateral aspect of the lateral ventricles appears to be clean, this is not the case here. There is thickening that is somewhat nodular along the medial aspect of both lateral ventricles. This thickening is more pronounced here in the region of the foramen of Monro, which explains the obstruction at this level and the subsequent dilatation of the ventricular system. It's mild, but it is dilated. So you have subependymal thickening of the lateral ventricles and mild associated lateral ventricular hydrocephalus. This nodular-like thickening extends to involve the third ventricle in this region and goes all the way down to involve the pituitary stalk, or what we call the infundibulum. You'd also wonder if the area below that, which is the optic chiasm, is involved as well. Now, before we proceed with this case, I'll direct your attention to one important fact. Notice how the abnormality is relatively hyperdense. The density is high. It's higher than the cortical density that we talked about, and definitely higher than the white matter adjacent to it. Remember that this study is done without administration of intravenous contrast, so this is spontaneously hyperdense. As a basic rule, the two things that are spontaneously hyperdense without contrast would be calcium and hemorrhage. And as you could tell, this is not calcium, it's different than the bone density, and it's not hemorrhage. The distribution would be unusual. You're left with the third possibility for spontaneously hyperdense abnormalities, and that's a highly cellular lesion. So tumors or neoplasms with condensed cells would give you a high density without IV contrast. And the classic tumors that are bright without contrast would be meningioma, lymphoma, germinoma, and medulloblastoma. So meningioma would not fit here since it's an extraaxial lesion. You have to think about tumors that could spread in this fashion. That would leave us with lymphoma, germinoma, or medulloblastoma. Seniors would also think about other entities that could give you thickening of the ependyma, and these would include an infection causing ventriculitis. However, in that case, it wouldn't be this thick or nodular, and the presentation would be totally different. You might also think about spread from other primary brain tumors such as glioblastoma. In that case, it would not be hyperdense. Keeping all that in mind, it's reasonable to proceed with an intravenous contrast study, and here you're looking at it. The intravenous contrast study demonstrates the same expected abnormality, but in a better fashion. Now you see thickening of the ependymal lining, which is nodular and extremely thick in some areas, such as at the region of the foramen of Monro. This abnormal enhancement and thickening extends to involve the pituitary stalk, and it also involves this posterior area, which we would better address when we look at the sagittal imaging. Now here's a look at the sagittal with intravenous contrast enhancement. The abnormality that you see here is that ependymal thickening that we saw on each side of the lateral ventricle. You see the extension of that abnormality to involve the pituitary stalk, which is thickened and enhancing. There's also thickening and enhancement along the floor of the third ventricle. This thickening overlies the mammillary body, the tuber cinereum, which is part of the hypothalamus, the infundibulum, and the region of the optic chiasm. Once you go back to the Radiology Bits tips and tricks clip, this area would be more understandable. It's also more obvious on the sagittal image that you have these areas of nodular-like enhancement here. For example, this area overlies the bone here. This is the sphenoid bone, an area called the planum sphenoidal, the flat sphenoid. To complete the case, this is the right and this is the left orbit with the optic nerve sheath complex behind. Note the difference in appearance between the right and the left. On the right, we have this segment of optic nerve enhancement. This is abnormal. And this fits with involvement of the optic chiasm extending anteriorly into the optic nerve. So this is also tumoral involvement as well. Honestly speaking, the enhancement of the left optic nerve sheath complex, these areas here, are also suspicious for involvement. We agreed that this pattern of enhancement would likely be due to lymphoma or spread from a primary brain tumor that is hypercellular. Now I'll give you more history. This is a patient who was known to have a supracellular germinoma. Although the germinoma was successfully treated in the past, this has recurred in the form of this type of involvement. So the case is consistent with the progression of known metastatic germinoma. Now let's review what we learned. We learned that the gray matter looks white and the white matter looks gray on a CT scan of the brain. We talked a little bit about ventricular anatomy and the floor of the third ventricle, and we know that the ventricle should have no abnormal lining. Then we saw abnormal enhancement of the lining of the ventricle, and the differential would include infections or neoplasms as major categories. We also agreed that the clinical presentation of infection would be different, and the appearance would also be different. You'd have thin enhancement in ventriculitis without nodularity. More so, with ventriculitis, you might have associated periventricular edema, which is not the case here. Then we talked about things that could spread along the ependymal lining, including lymphoma, metastases, or primary tumors. We also discussed the fact of some neoplasms being spontaneously hyperdense without intravenous contrast, and those would include meningioma, lymphoma, germinoma, and medulloblastoma. From the start, we excluded meningioma, which is an extraaxial lesion. We also excluded glioblastoma since it's not spontaneously hyperdense. We talked quickly about the structures that form the floor of the third ventricle. And we also learned that if you have lesions that involve the optic chiasm, make sure that the optic nerve is not involved as well. With that, we end the case. Thanks for watching, and see you with more cases later.